everyone for joining in. My name is Dr. Joni Nelson. I am an assistant professor in the College of Dental Medicine at the Medical University of South Carolina. And I'm going to spend some time talking with you about advancing rural oral health through value systems and policy, which was a part of my MRDA award work. We were really excited to start this work. It's been bound in the foundation of a lot of things that have prioritized population oral health through both clinical practice and policy, and lots of different publications. There's been a lot of different strides made to understand determinants of health and population oral health. There have been a few Institute of Medicine reports that really focus on policy recommendations, oral health care access and limitations, and really the policy implementation pieces. And a lot of this work was followed by the U.S. Department of Health and Human Services. They had a huge framework around oral health, which emphasized a lot of disparities and interventions that bring around dental health equity. We saw a lot of work come through the National Rural Health Association, as well as recently some practice transformation work from CareQuest. So as a part of, just kind of additional context, this was an effort of the Kaiser Family Foundation, who created this map where they described how Medicaid was expanded under the Affordable Care Act, beginning by being adopted by several different states starting in 2014. This policy created a critical pathway to increase dental care among low-income adults and provide access to services for adults enrolled in Medicaid. However, the American Dental Association reported that analyzation from multiple studies 3 years after the Affordable Care Act was implemented, there were a lot of mixed results shown around the actual usage of dental services themselves. And here, the American Dental Association, we cannot have this conversation without talking about COVID. But it provides some insight into decisions made around Medicaid populations amid COVID-19. So this is some post-dated data around the early onset of COVID. Around 99% of dental practices in the US were open, and 40% said, hey, we're having business as usual in terms of patient volume. However, the pandemic has caused around 8% of Medicaid dental providers to disenroll from the program, and an additional 15% around the onset of COVID-19 were considering disenrolling. And around 20% of Medicaid providers overall have decreased their number of Medicaid patients that they can actually accommodate since the onset of the pandemic. So this is just a really big hit here as it relates to population oral health and that contextualization. So the proposed investigation that I really targeted my aims around was evaluating trends in dental health behaviors and beliefs, those value systems, and how they stratified across socio-demographic factors, and then examining the degree to which Medicaid expansion impacts dental service utilization. So this work was framed around the McLeroy social ecological model, and it really emphasizes the realities of the context and impacts on health. It's based on both internal and external factors, and I really tried to focus on how those socio-demographic factors shaped overall oral health behaviors and beliefs. So this approach aligns with the literature that it describes health insurance, and particularly as not always the only factor that can improve access to care or influence access to care, excuse me. So our analytical approach, we utilize the American Medical College's field survey. It's a consumer health survey, and they conduct it twice a year. It really emphasizes the consumer perspective. Our main outcomes of interest were our dental items, and that was, whether dental care was needed in the past 12 months, the reason for that visit, if dental care was needed but not obtained, insurance status, and their belief status on their overall dental health. So through quantitative analysis, we use descriptive and bivariate analyses and multivariate logistic regression to tease out these differentiating factors and tendencies among the respondents as it related to their health behaviors and beliefs. We reported a 95 confidence interval and odds ratios with a significance level of 0.05. So just digging in straight to some of the results, our preliminary results here, we had, almost half male and female participants. The most common type of education was high school and some college. We noticed that our three higher tier levels of income were between 50 and 75. And then we had those that were under 25 a year. Our demographics, really, we wanted to focus on looking at where they resided, as well as if they were in an expansion versus a non-expansion Medicaid state. The majority of our participants were white, then African American, and then we have varying ethnicities across the board there. But what we really found was pretty, expected, was the ideal around dental insurance and self-perception. A lot of folks saying, pretty good dental health, and more than the majority had dental insurance. But when we started to look at rural versus urban, respondents in urban and suburban areas had a higher odds of rating their oral health as excellent in comparison to those in rural areas. We saw that about half and half said, hey, in the past 12 months, I could get dental care. And then some said, no, I really couldn't get dental care. When we looked at respondents in rural versus urban areas, we saw that respondents in suburban areas had a lower odds of saying yes than those in rural areas. And we also saw that almost all age groups were at least twice as likely to say they couldn't find a provider that actually accepts their insurance. This is pretty in alignment with what we have been seeing in the field. A lot of participants said, I just could not afford my dental care. The second top reason was I couldn't find a provider who accepts my insurance. And then the third being, I could not find a provider that would see me regardless of my insurance. But that top reason being not able to afford. So just some of the big key takeaways as we continue to dig further into the data analysis. We know that this is a pretty limited data set. However, we know looking forward that the way that respondents select their answers could be influenced by COVID-19. So we're looking ahead and thinking about how that may be an associated factor. So this study overall does give us some clarity on how policy may coincidentally impact oral health access and equity. So we're going to continue to further our study by taking our qualitative arm and looking into the perspectives of clinical stakeholders around Medicaid expansion. And that phase 2 is literally focused on the rich understanding of medical and dental providers via a national set of representatives. So speaking with individuals who are representatives from the National Dental Association and the National Academy of Practice. And our second part to this phase is really digging into doing a policy analysis performed through a really explicit document appraisal on the dental benefits for Medicaid beneficiaries. So we are in great hopes that this has some big implications for future policy and practice. We know 3 key areas, one being contemporary policy relevance. In our experiences with working in rural and underserved communities, we know firsthand, state and federal policies, although well-intentioned, can really impact rural healthcare systems differently than urban. So in our current administration, we're likely going to experience additional fluctuations in policy and funding for dental care, and the impacts of COVID-19 and other funding relief packages. We're really going to see some differences there. And it's important that policies can support clinical provider workforce retention and recruitment. And it's just as equally as important as advocacy for funding mechanisms, sustaining rural health clinics, as well as community health centers. We know some of those social influences, such as environmental surroundings, social capital, some of those interpersonal relationships, and life course barriers are going to continue to play a role in optimal oral health status, but by pinpointing which population groups are most likely to have those unfavorable outcomes, we can use that information for targeted policy development. Our future study and current results will provide some sort of leeway and understanding on interventions that can bridge health services and systems to effectively address the delivery of quality oral health care services to Medicaid populations. And I want to thank you so much for joining in today for this chat. And if you have any questions, please don't hesitate to contact me. Thank you so very much.